Hi, we'd like to welcome you today to the discussion on the finances of healthcare. Speaking today is one of my coworkers, Elaine Youch. She's the Associate Chief Revenue Officer at the University of Kentucky. And my name is Pam Ryan. I'm a registered nurse, and I'm the Director of Utilization Review in the Clinical Documentation Program. We're going to talk a little bit today about different aspects of finance. We've got the Affordable Care Act that we're going to discuss. Going to learn a bit more about Medicare and Medicaid, as well as what the role of a healthcare provider has in the hospital regarding the finances. We don't always like to talk about finances in the healthcare world, but it is something that we do have to learn about and deal with and just embrace as we go about our care. The clinician's role in the payer reimbursement is very important, and I'm going to discuss a little bit about my two departments. The first is going to be the Clinical Documentation Department. In the nursing world, when I was in school, and hopefully nurses today are learning the same thing, that if we don't document what's happening, it really didn't happen. And documentation is a very, very important part of the medical record of the patient. The documentation in the record is what leads the coding staff to a specific diagnosis code. That code gets placed on a claim, and that claim goes to the payer. There are a lot of things about the different codes that might be aggregated together at a later date. For instance, if someone was watching how many smokers we have in the state of Kentucky, they might gather claims data that's coming from a public reporting site or something like that, and look at all the people who have a code for tobacco. And one of the things that you might want to do as you're gathering that data is to identify if you've improved with education, the smoking rate in the state or something. So it's really important that the right codes and very specific codes are on every patient chart, even very minute details like tobacco use. One of the things my documentation specialists do is we review the chart and we make sure that the chart has all the most accurate and appropriate documentation on it. Sometimes new residents don't always want to code properly or diagnose something properly. For instance, a very common issue is that they will talk about a patient who's short of air, who has a fever, who has some IV antibiotics, they're on oxygen, and they are saying they just have shortness of air. That is a code, and it is a code that could be put on the claim, but it is also a symptom. Medicare expects that our doctors are always diagnosing patients when they spend time in the hospital, so it's very unusual to have just a symptom as a code. The nurses in the clinical documentation program would review that chart, look at every aspect, including vital signs, the different treatments that are being given, the different labs, and they would go back to the physicians and say, is it possible that this is pneumonia? Is it possible it's a congestive heart failure? Is it possible that it's a COPD exacerbation? Or any other variety of diagnosis that could fit into that category. So that would be the reason for admission, and that is an important aspect. It decides at the DRG that Elaine's going to talk about later. And the comorbidities are also very, very important part of the chart. Let's say you have a patient who does have pneumonia, but they also have COPD. That patient is very sick compared to a patient who has pneumonia and is young and doesn't have any other comorbidities. So capturing all of that information for the chart, for the payer, to make sure that we get paid for how sick our patients really are. A lot of this is just capturing the information accurately because we do need to get paid for the severity of illness of our patients. Some of the things that we do that help us get the correct diagnosis and different procedures in that chart seem very administrative to physicians and to nurses. It's very time consuming. The electronic medical record can be time consuming. But if we don't capture all of the correct diagnoses and chart and procedures, we will not be able to capture all of the charges that we need to capture. And the accurate charges also leads to accurate payment. We should be paid for the care we provide. We should not be paid for care that we don't provide, so the accuracy of the chart is extremely important. But if we are caring for a very sick patient, we should get the highest rate that we possibly can. It is important that we keep the doors of the hospital open. We provide a service to the community, and it is a business aspect to it that we don't like to talk about as healthcare providers. But it is a very important part of the hospital admission. One of the nurses who worked for me for a long time used to say that we can't fax the patient over to Medicare. So we only have the chart at the end of the day, which is why it's so important to make sure that documentation is accurate and it's written in the chart in a way that you can read and makes sense at the end of the day. Because auditors will come back later. They can come back 3, 4, 5, sometimes even 6 years later, review charts and decide that care was not provided in an appropriate manner, or perhaps our diagnoses were higher than they believe. Maybe the chart doesn't reflect how sick the patient really was, and we're trying to bill for the highest level, and it's not appropriate. We then have to go and appeal and do things like that. So it is important at the time to make sure that that chart accurately reflects the severity of illness of our patients. Another thing that we are doing in my department is looking at mortality charts. When patients are do expire, sometimes we found that physicians didn't always finish a chart. Let's say that a patient was coded and they were placed on a ventilator as they were trying to save someone's life, and acute respiratory failure is a diagnosis that would be appropriate in that setting. But as they're trying to save that patient, nobody's really stopping to document in that chart, so they will have to do it after the fact. And so we watch every mortality chart to make sure that we are capturing how sick those patients are who die. There are ways that we are measured and compared to other facilities, and our mortality rates are one of those measures. So making sure that all of that documentation is accurate and appropriate is important. The other part of my job is the utilization review department, and also may be considered case management in many hospitals. We do all of the decisions about what's an inpatient, what's an observation, length of stay, all of those things. There are multiple levels of care in the healthcare community. There's an inpatient level of care, that's the hospital. There's outpatient level of care that has many different aspects to it, the emergency room, a clinic visit, a hospital outpatient procedure where someone has a procedure and goes home. All those things are considered outpatient. There's also an aspect in the hospital called observation that's considered outpatient as well. And then I'm going to talk a little bit more about that. Skilled nursing is another level of care that is in the community of healthcare, and that's where patients are getting perhaps wound care or physical rehab in a nursing home setting. It's often referred to as subacute care. You could also have acute rehab that's at a rehabilitation center for physical rehabilitation, and home health care is another aspect of different levels of care that patients might need. Home health care would be after a hospital admission. It might be ordered from a clinic setting, but it provides additional support for a patient who might need IV antibiotics. They might need wound care. They might have a line in place that does need to be managed. They might have a wound vac or other very complicated things. So we send complicated patients home all the time. Is somebody an inpatient or observation? That's a very difficult question. Medicare tells us that it's up to the physician to make that decision. Our physicians have trouble sometimes making that decision because Medicare, these are Medicare rules that we're dealing with here, and they can be very difficult to understand. It's kind of like dealing with the IRS. When you deal with Medicare, there's a lot of rules. My nurses have become experts at some of those rules. We guide the physicians and make sure that they are making the proper decision. The inpatient level of care is typically a patient that cannot get care provided anywhere else. They can't get that kind of care at home. They can't get that kind of care in a nursing home, in a subacute rehab, and it's not appropriate for an observation level of care. For instance, someone on a ventilator, someone who's getting IV antibiotics 3 or 4 times a day, someone who needs nebulizer treatments multiple times a day, someone who's being monitored closely for their respiratory status. Very sick patients typically have to be in the inpatient setting. For observation, if you kind of think about the way the word observation brings to the discussion, we're observing the patient, and a lot of times you might have someone come in with chest pain. We're observing them to see if there's something else going on. Do they have a pulmonary embolism? Do they have a MI? Do they have other things that maybe haven't revealed themselves yet? Sometimes in observation stay, you do discover they have a pneumonia or some other thing that does need to have a higher level of care treatment. That patient will move from an observation to an inpatient level of care when you determine what's wrong with the patient. It seems like a pretty simple discussion as I'm talking about it here, but it is quite complicated. We do have to involve the physicians. We often have a physician advisor involved in those decisions. And we have to tell the patients and try to explain to them the difference between inpatient and observation. It does affect a Medicare patient's benefits. They do have to be an inpatient for 3 days to be able to go to a nursing home's level of care on Medicare's dollar. If they are in observation and they do need to be placed in a nursing home, they are facing a private pay situation, or perhaps Medicaid would pick up their hospital nursing home care. But often there's a lot of emotion involved with families and with the patients on something like this. Patients also have to pay for their own medications. The thing about the nurses in my office that we discuss all the time is that we need to get this status right so that we can have accurate billing. We don't want to bill people for Medicare inpatient if that's not appropriate. We want to bill for Medicare inpatient when it is appropriate every time. So getting this right, despite the different factors that the patient might have about a nursing home care or whether they want to be inpatient or observation, it's not really a choice of the patient, but it is based on what kind of care we're giving to the patient and how sick they really are. The other thing that we do that spend a lot of time doing in our hospital is pre-authorizations with the insurance companies. We talk to all insurance companies, all levels of Medicaid, and we do have to ask them to give us an authorization. Many times our authorization begins at the time of admission, and we have to get all the days approved until the time of discharge. Sometimes we have to call them every day. Sometimes we call them back every 3 days. It just depends on the company, and they give us guidance on when we are to give them a call back. In order to get our clean claim out the door and to get paid fully, we do have to pursue all approval and the authorization prior to discharge, and so we don't have problems with our claims. But this is a very time-consuming effort. It is difficult because the payers obviously would rather pay a lower rate. Inpatient is a higher rate than observation, so the payer often wants to debate with us about whether it's going to be inpatient or observation, and then we have to go to an appeal level if we disagree with them. So that happens quite frequently, and like I was talking about Medicare, many of the payers also come back and audit their charts at a later date and see if we were being honest about it, or if there was anything that they can find to give us, to take back their money and give us a lower rate. That can happen several years later, as I've already discussed. Some of the things about length of stay and readmissions, we do monitor readmissions in my office. We make sure that the payers are aware. They're often also watching that kind of thing. Sometimes the payers make us combine admissions when we have a readmission, and that means they only pay us 1 DRG for all of the hospital days, even though the patient comes in twice. The payers believe that readmission is a failure of the first admission to provide all the adequate care and also to provide post-care for the patient. So that is why they will often combine our DRGs, but sometimes the length of stay is exceeded, both the payer and when we want the patient to stay in the hospital. Patients who have social issues often are in the hospital waiting to go to nursing homes. Sometimes we have difficulty finding a nursing home for them. Sometimes we have guardianship issues or a lot of other things that cause the patient to have a higher length of stay than is necessary. This clogs up the hospital system. When we have a patient who doesn't go to the right level of care when they're supposed to, then our ICU patients can't go to the acute care bed. Our ER patients can't go to our ICU beds. And we have a lot of people sitting in the emergency room waiting for beds when those things happen. This is a fairly, well, it happens a lot in a hospital like our size, and it happens in all hospitals. But it is something that can be dangerous for the patient because emergency room nurses are very busy. So moving these patients through our system, getting them to the right level of care is very important for just the safety of all of our patients. And now I'm going to, let's see, I'm charging and getting paid for services. That's the last thing I'm going to discuss today. For hospital charges, as I talked a little bit earlier, healthcare providers believe that charges are administrative work, but if we don't charge for all of the things that we need to and all the resources that we use, then we really can't provide for the next patient. It's very important that we are charging for all of the care that we can. Nurses often have charge sheets. You know, we used to have charge sheets. Sometimes you have to use barcodes now to make sure that every time you take a chucks out of a storeroom and put it in the patient's room, that we're billing for all of that. But it's important for people like Elaine so that they can understand how much it costs to be in the hospital and how much we're charging patients. Patients also look at line item amounts on their bills, so they will sometimes come back and dispute charges that are on there inappropriately. So, but for nurses, why do you care for healthcare providers, physical therapists, doctors? Why should we care about all this? Well, to make it personal, you know, we all need a job, and when we're in a job, we all want a raise. So those are very personal things for each person, and that's a good reason to capture all the charges for the care we're providing. But also, when we're doing the budget, if we're having budget issues and we fail to capture all the charges we've given to every patient, then it's very likely that our budget is going to be cut the next year. Sometimes staff at the bedside are cut. That can affect the kind of care we're giving, how many patients receive ulcers because they're not turned enough. We do need staff at the bedside. That's one of the things in my office we often discuss, is that when we produce revenue, when we get those authorizations, when we get that DRG to the highest level, that we're really doing that not for our purpose but for the purpose of the patient, because the more staff that are at the bedside, the better the care for the patient. So there are lots of reasons to care about why charges are captured appropriately, and you know, it's just something that you should all be concerned about. I'm going to pass it on to Elaine.
Okay, and Pam and I have heard many, many times, no margin, no mission. So I'll try to socialize some terms that may come in handy sometime for you as you're going through your studies, or when you begin in the hospital setting and start to communicate with people a little more that have been around for a while. We'll talk about some of the different payers that we have as an institution. One of our largest payers is Medicare. And Medicare caters to people who are over the age of 65, or those who have renal failure and they're in the Medicare program, or those that are disabled for one reason or another. And there are different components of the Medicare program. There's a Part A component, which covers the stays when you come into the hospital and have, when Pam talked about a DRG, that's for a Part A stay. And we'll talk a little bit more about that in a few minutes. With Part B, that's for physician services, and for Part B, there is a slight premium to Medicare enrollees for that service, as well as they have co-insurance and they have deductibles. For the Part A, there's no premium. So if you're a retiree and you draw a Social Security check, then nothing comes out of your check for Part A, only for Part B. And then there's also a Part C, which is more like a traditional managed care type plan. It's called Medicare Advantage, and it's a little bit different in that your premiums, you still don't pay a premium, but you may receive more benefits for things like they oftentimes offer a silver sneakers club to seniors to keep them active and keep them healthy. And then the last thing is a Part D benefit, which is the prescription drug benefit for Medicare and Social Security beneficiaries. So to talk a little bit more about the Medicare reimbursement, with inpatient hospitalization, Pam mentioned DRG, which is a diagnostic related group. And in those groupings, there are different things. For example, there's a DRG for a heart transplant, which is the highest weighted DRG. And when I say weighted, each of the DRGs are assigned a value. And that value is based upon the complexity of the care for that patient. So when we talk about a higher case mix index, that DRG is directly related to that case mix index. And you'll hear that a lot when you go into the work environment. The other thing is outpatient services, and those are paid based on APCs, which are ambulatory payment categories. And they're very similar to the inpatient DRG, except they're for outpatient services. And you may have multiple ones on an outpatient claim for a patient. Fee schedules are another thing for labs, for example. When you have lab work done as a patient in the hospital, many of our payers, I can't really think of any that don't pay on a fee schedule. And that means you would bill a code, and whatever they say you get, no matter what your charges are or what the case may be, that will be your payment. There's home health agencies who are paid on case rates, and then skilled nursing care, which Pam talked a little bit about earlier. In the skilled nursing setting, they're paid on case rates as well. That's for certain lengths of time to the seniors or Medicare beneficiaries who go into a skilled nursing unit only have a certain number of covered days. And then oftentimes, depending on their economic status, Medicaid may pick up the rest of their stay, or they may be responsible for it through their private funds. Medicaid is another federal program that's administered through the state. And it's for those, or traditionally, it's been for those that are 100% of the poverty level, the federal poverty level, or those who are pregnant, disabled, blind, aged, and for children based on the child's economic status. But back in January of 2014, Medicaid expanded its program, which I'm sure you've heard lots about, and that made it possible for able-bodied people to receive Medicaid benefits. And it's based upon their economic level. If they're 138% or less of the federal poverty level, they automatically qualify for Medicaid. And the provisions for Medicaid are the same pretty much as Medicare. You have hospital services, physician, home health, skilled nursing, and there are special homes, they call them waivers, such as brain injury homes or things of that nature. And then pharmaceuticals are also covered by Medicaid. The difference is Medicaid right now has no copays. There was one point in time where there may be a $2 or $3 copay for an outpatient service or $50 for an inpatient. But that was alleviated a couple of years ago when Medicaid expansion came in. With Medicaid reimbursement on November 1st of 2011, the Medicaid reimbursement and care provision completely changed. We moved to Medicaid managed care plans. There were 5 of them in the beginning, and at that time we started to see differences in reimbursement. We saw differences in authorization requirements. The inpatient hospitalization continued to be paid based upon diagnostic related groups, DRGs, just like Medicare. Outpatient services, for the most part, were covered on a cost basis. And what that means is we would submit a charge via a claim to the payer, and whatever our cost to charge ratios were, that's what they would pay on that claim. There were some fee schedules, lab for example. Just as I said earlier, lab fee schedules are in existence for almost every payer that we have as an organization. And then physician services are paid on a fee schedule. And then last, the Medicare patients who have a lower economic status may qualify for Medicaid as well. And when that happens, the Medicare coinsurances and deductibles may oftentimes be covered by Medicaid. Another type of payer that we have is managed care. And managed care can mean lots of things. It's a system of health care delivery that tries to manage the cost of health care. And there are different kinds of subcategories of managed care. One is an indemnity plan. And in an indemnity plan, you may have an insurance, and in that insurance, you can choose to go to any doctor you like. You're not in any type of network, but you may have a higher out-of-pocket amount. And when I speak of out-of-pocket, I relate that to coinsurance, copays, and deductibles. The next kind is a little more confined, and that's a preferred provider organization. And in these organizations, you have a network of providers that you're allowed to use for your health care. And if you choose to go out of that provider network, you may have a higher out-of-pocket. And these plans usually have office copays and an annual deductible. The next kind, which is a little more restrictive, is a point of service plan. And in a point of service plan, those are typically provider networks such as a physician provider network, and you have a primary care physician, and all of your service is contained to that network. And again, if you go out of network, your costs are even more than they would be in a PPO. And the last most restrictive type of plan is a health maintenance organization, or an HMO. And in an HMO, you have a network and you are confined to that network. You have a primary care provider who has to refer you to any specialty care you may receive. And then there's very tiny copays, $10 or $15 or $20, somewhere in that neighborhood. And there's no deductible if the care is provided within your network. And if you choose to go out of your network, you would need to get special permission from your HMO. The only HMO plan that UK contracts with is its own internal employee UK HMO plan, and that's beneficial to both the university, its employees, and the hospital. And with managed care reimbursement, if you'll notice this slide, it says no two contracts are the same, and that's true. We have hundreds of contracts with different payers, anywhere from payers that have maybe 1,000 covered lives to those that have maybe 300,000 or 400,000 covered lives. And in those contracts, there is always some kind of language in that contract that may differ from all the others. And then contracts are made up of different payment methodologies. You have the DRG that we've talked about a lot, which is more of a case rate type payment methodology. So if a patient comes into the hospital and they have numerous services performed that we would charge for that, we would only receive one payment, regardless of what we do for that patient during their stay. The other thing is visit rates. So if you look at the outpatient side of the house, we have lots of visit rates. For example, if you have an MRI done, you would receive one payment for that MRI. And if you have an MRI done and have a clinic visit, you would get two separate payments, but both of those are visit rates. The other thing that we like most is a discount off charges. And that's what I mentioned earlier, where you have a charge that you submit and the payer pays a % of that charge that's established through your contract. Fee schedules are the other alternative, which you bill a widget and you're paid for a widget. Those are starting to disappear. They've been in existence for a long, long time, but now that we're moving into more for performance and value-based payment worlds, we're kind of seeing those start to disappear. And then we have certain carve-outs. Because UK has many different specialties, we have the advantage of asking payers for carve-outs for certain services. For example, we're a level 1 trauma center, so we may ask for carve-outs for trauma. And what a carve-out would mean is we would get additional reimbursement for those services. Mental health is another thing we may carve out for. Transplants There are only 3 hospitals in the state that can do transplants, and we're one of them. So that's one of our niche services that we choose to carve out. And then stop loss, we've got first versus second dollar. That's kind of confusing, but what stop loss is oftentimes we may have patients that come in that have many issues, and their charges accumulate quite a bit while they're with us. When those cases are with us, we may get extra payment for them outside of that DRG rate, and that's what a stop loss is. And then special payments, many of our providers want to put what we call lesser than language in a contract. And lesser than language means if our charges are less than what that DRG payment would be, that they would only pay our charges. We try to avoid those, but sometimes we have to give that up to get something better in our contracts. Now I want to talk a little bit about pay for performance, and we actually redid these slides about a month ago, and when I start to go through them you'll see they're already outdated because of the rapid changes we're having with our new leadership in federal government as well as state government. But first I want to talk a little bit about the Affordable Care Act and the original intent of the Affordable Care Act. Originally, it was meant to expand care for individual and employer people, I don't know what to call them other than people. There were health insurance exchanges created. So, we as a hospital, and Pam, you recall this, we had many people who were uninsured. Mm-hmm. And once the Affordable Care Act came in for UK, it was a big benefit financially to UK, and it was a big benefit to the citizens of the Commonwealth. Not only did we have health insurance products that they could receive federal subsidies to obtain on the health exchange, but that's when Medicaid expansion began. So we saw lots more covered lives, that people that we were able to treat that hadn't had medical care for years. Then there was also health cooperatives that were created. Now the health cooperatives haven't worked out very well, and we'll talk a little bit about that later, but the original intent of them was the federal government gave grant money to a certain provider in the state or payer that would create a health cooperative. And those cooperatives offered lower premiums for those members on the exchange, and the intent was a really good intent. However, the cooperatives didn't have enough money to sustain, so many of them have gone out of business throughout all the expansion states, Kentucky being one of them. We also saw lots of insurance reforms. We saw that children through the age of 26 could be covered on their parents' policies. We saw pre-existing conditions disappear from insurances, many good things, and then Medicaid expansion at the end. And the delivery system reforms, we saw accountable care organizations develop, and what those are they're similar to a medical home. So you have a physician that would manage your care. They would have care coordinators to take care of you. And, so for some of our seniors, that's a really good plan. They would call these seniors to make sure they were taking their medications and doing the things that they needed to do to keep them out of the hospital. We saw more outcome-based payments, new payment systems, value-based purchasing, and bundling around episodes of care. And what bundling is you may come in for a hip replacement. Thank you, Pam. You can tell I have no clinical expertise for a hip replacement. And what bundling would do is bundling would say, okay, any test that you had 3 days prior to your hip replacement, plus the cost involved in your hip replacement, and 30 days post-care are all covered in one payment. And that payment is shared between different providers. That's kind of a new philosophy for us as providers, both physicians, skilled nursing facilities, rehabs, any of those organizations, and we don't always all like to play together. So that's become a bit of a challenge, and I think we'll see that a little bit more in the coming days. So just to summarize, the primary objectives of the ACA were better care, better insurance, and better systems of prevention and public health. Lots more grants and incentives to businesses who would support healthy employees. Many businesses now, including UK Healthcare, have wellness programs, and in these wellness programs you may be subsidized for a Fitbit. There may be smoking cessation classes provided for those who are smokers and need help to get away from that. There's also drug lifetime limits. The exchanges were created. There's rate review processes. It was really meant to be a good thing. But then the future happened, and we're in the future and the present now, and during that time we've seen new movements toward healthcare reform. And as you recall, the first thing our new President Trump wanted to do was repeal and replace the ACA. It was a good thing, but the Republican administration believed that it could be better. So on day one, what did he do? He worked to keep his promise to repeal and replace the ACA. There was much work done to change the plan administratively, and he was relying on legislative efforts to make that happen. So what does that mean? It doesn't immediately unwind all of the ACA. It doesn't immediately provide authority to ignore or alter the portions of the ACA that were set into law. And those were things, for example, I talked about the students under 26 that can still remain on their parents' insurance, pre-existing conditions. Those things are in law, so they can't be as easily changed as other things. And it hasn't defined the impact on the individual market. And when I reference individual insurance market, that's the exchanges, that's even plans that aren't on the exchanges that offer individual coverage outside of employer coverage. And what do these changes mean to Kentucky? Because as you know, last year Kentucky moved to a Republican administration, and our governor has many plans for Medicaid reform. Medicaid expansion grew much more quickly than what was originally anticipated. It was originally anticipated to have 307,000 members after 2 years. Well, we were at 307,000 members after 6 months, so it grew much more rapidly than what had been planned. And it's very difficult for the state to sustain this Medicaid growth financially. In the beginning, when the expansion was started, it was completely federally funded, requiring no state match. Well, beginning January 1 of 17, the state had to begin to pay a match for the dollars it received. And it had to pay 5%, which sounds tiny, but 5% on billions of dollars is a lot of money that the state doesn't have to provide. So the governor wants to look at other alternatives. And one was to create a Medicaid waiver. And the Medicaid waiver was meant to only create changes for those under the expansion rule, which would be able-bodied adults. So there are different things that we'll talk about in just a few minutes that we may do to create more ownership by the member for their coverage. If you look at the state insurance market, Medicaid is almost 1.4 million enrollees, and the next closest is Medicare at 862,000. So 52% of the entire state population is covered by a governmental plan, either Medicare or Medicaid. And that's kind of scary when you think about it. So 30% of the commercial insurance and 70% of self-funded plans. It's very government dependent. And these are some of the dollars involved in the Medicaid expansion. The general funds, the expansion piece of the general funds is $77.1 million. So 5% of that, like I said, is a lot of money, and it's projected to go up to $180 million in fiscal year 2018. The proposed changes in the waiver are premiums for Medicaid enrollees, And these premiums range anywhere from $1 to $15 a month, with $15 being the maximum for the first year. And again, this is just for able-bodied adults. The employer health insurance premium support. So what may happen, as you know now, there are current members of Medicaid that are working adults. They may work at Walmart, for example, or they may work at UK, for example, but they have a lower salary threshold. And as a result, they still qualify for Medicaid. So what Medicaid would do is Medicaid would pay those employers the premium to put them on the employer health plan as opposed to Medicaid, to save dollars in the plan. And then they would create what's called My Rewards account, and that's very similar to a flexible spending account. So members can do different things to have money added to their account. For example, and we'll talk about the SUD pilot program, the substance abuse pilot program in just a moment, but if members agree to go through a substance abuse program, they would have money put in their flexible spending account to spend for other health care needs. And then non-emergency transportation is something that has been covered in the past to get people to their physician appointments and to the hospital and things like that, but that are not emergent. Well, those will no longer be covered. So that will save dollars, but it will hurt providers and members as far as making their appointments, because many of them don't have vehicles or they don't have a mode of transportation. So those are challenges that we as providers will face. And then non-payment penalties. If a member doesn't pay their premium for one reason or another, they will have a chance to miss that premium, but if they don't make it up within 3 months, they would lose their Medicaid benefits. And then after 6 months, they could qualify again, but if they don't pay again, they're completely out of the Medicaid program. And currently, we have Medicaid retroactive benefits. So if you come into the hospital and we find that you are qualified for Medicaid, we can go back and get benefits for you to cover you from the first part of your stay until you leave. Well, with the new plans, that won't be possible for this expansion population. And those are large dollars to providers. Those are things that will be difficult for us to overcome as a provider financially. The next thing is community engagement. These members will be encouraged to seek employment in the community. So they'll do job resume planning. They'll have lots of opportunities to learn how to go out and look for a job and have opportunities to be helped in the job field so that they can become employed and drop from the Medicaid rolls. And the next thing is the substance abuse pilot program. There are lots of opportunities there. The coverage has been expanded. I mentioned the flexible benefit, how they can have points added if they seek outpatient or inpatient substance abuse counseling. Those are things, as you know, that's a growing epidemic in Kentucky and many other states. So the goal is to help these people heal from their illnesses and be productive members of the community. The last thing is chronic disease management. Chronic diseases, one example is diabetes. Each diabetes member will be encouraged to seek diabetes planning programs so that they can work to control their diabetes and do things that could potentially keep them from needing medication in some sort or some way. So there's lots of good things with the changes in the health waiver, and the new Medicare commissioner or Medicare secretary, I suppose, her name is Seema Verma, and coincidentally she helped our governor write the new waiver program. So it's expected that the waiver program will pass, and if that happens, we'll see some decrease in coverage for the people that hadn't had health coverage in quite some time, but their coverage will be in their own hands. They'll have to be more accountable for their coverage, which will be a good thing. So these are some of the things that we're seeing in the payer landscape, and I know you'll probably have lots of questions for Pam and I, and we will make sure that our contact information is available and you can email us directly with the questions that you may have. Thank you for your time today.